Good afternoon, friends. Welcome to Karnataka ENT Hospital Innovative Masterclass series of programs, which you have been conducting for the last 3 months. Thank you very much for your patronage and unstinting support. Today, I am going to introduce a person, if I would like to emulate or have like an idol, whom I would like to have a top one priority. Okay. I've been working with this rare person for the last almost 10 years on a specific area of our ENT, advanced ENT, taking to the next step, that is endoskull base, anterior as well as lateral skull base surgeries, under whose guidance I could have never imagined otherwise, under whose guidance and mentorship, I could get some experience in this field. That is Dr. N.K Venkataramana, for whom we fondly call NKVR. Okay, and he is the founder, chairman, and chief neurosurgeon of Brains, and an internationally acclaimed neurosurgeon, a researcher, and academician. These are some of the rarest qualities to get in a person. That is being a good surgeon, a researcher, and academician at the same time. Sir, after training in micro neurosurgery and neuroendoscopic surgery at one of the most prestigious institute of Germany, he served as assistant professor in the topmost neuro institute of India, that is NIMANS in Bangalore. Sir later founded the Manipal Institute of Neurological Disorders, which is popularly known as MIND at Manipal Hospital in Bangalore, and that he turned into a leading facility. Alongside, he also pioneered something unique, that is country's first GPL-enabled mobile trauma care service, an innovative idea uh, which he pioneered. And also, now he served as a vice chairman of Bangalore-based BGS Global Hospital. He was vice chairman as well as chief neurosurgeon there. That is where I got an opportunity to work under sir in this specific field of endoscopic skull-based surgery. Sir has published more than 100 papers in reputed journals, and also he has performed more than 30,000 major surgeries. I'm not talking about minor surgeries, major surgeries, and he has done number of conferences and courses. He has participated as a speaker, or a guest speaker, or a faculty, are countless. Like some of these events, I was very lucky to travel along with him. We did a workshop together, a live physical workshop together at Colombo, Sri Lanka, few years back, and he is the recipient of numerous prestigious award. To give few examples, Karnataka Rajyotsava Award in 2008, a prestigious award given out to one doctor every year, and also a C.V. Raman Birth Centenary Award 2015-16, and he received that coveted award from none other than our Honorable Prime Minister of India, Sri Narendra Modi ji. Okay, and he has been editor, assistant editor, and at different capacity in several journals, and presently he is the editor in chief of Brain Voice. In 2016, December 2016, he founded a new institute, a sort of own Botic Center of Excellence for Comprehensive Neuro and Spine Care, that is Bangalore Regenerative Advanced Institute of Neurosciences, a Brain Center, which is called in short. Okay, Brains is setting the gold standards in neuroscience with cutting-edge services encompassing prevention, awareness, advocacy, acute and chronic care, regeneration, most important, rehabilitation, research and training. Among the center's primary focal areas is to infuse vitality to brain health. With this introduction, I call upon sir to talk on this one innovative topic. That is, now almost everybody, many teams have started doing trans-sphenoidal endoscopic pituitary surgery. But what is most crucial in this? That is preserving normal pituitary. So when I asked sir what you would like to speak about it, he said we had to speak about something very unique, very important, very crucial for the safety of the patient. That is preserving normal pituitary, and he chose this. He always tried to be a different, to be different, not like other mainstream surgeons I've noticed, and I invite upon him to deliver this talk on this specific topic. Sir, thank you very much for being here. You can share your screen, sir.
Yes, yes. Good evening, everybody. Thank you very much, Dr. Prahlad, for your kind words of introduction, as well as uh, giving me this opportunity to be part of this prestigious webinar. In fact, it's a great opportunity to share this work, and most of the work is done along with Dr. Prahlad, and it's wonderful to work with him. And it's not that he has learned many things, but I do have learned many things from him, and working together is a great pleasure. And that is how we learn each other, and that is how we should set the trend, how we should go forward. And if you, the screen doesn't move, Dr. Prahlad.
Yeah, that is, sir, if you go to the right side down, there will be direction buttons of the PowerPoint. Yeah. Either right or left side, it will come, sir.
Usually it is there.
Yeah. Okay.
Yeah. So I've been doing, pituitary surgeries for almost now three and a half decades now. And initially, we all started this as transcranial procedures. And every pituitary we used to open, there used to be a craniotomy, retraction of the brain, reaching the pituitary gland, and series of problems. One of the problems being the hemorrhage, which is quite often with the pituitary adenomas, particularly with their giant pituitary adenomas. Now, if you see, look at the series, we had a male preponderance out of the 400 odd. Now it has become much more now, the numbers. Now, the length came with the advent of the microscope. We started doing the transnasal, trans-sphenoidal microscopic surgery. It's a very good procedure where you can go through the nose, either transeptal or paraseptal. So initially, we all started with the transeptal, where we used to open the mucosa and go all the way between the mucosa and the septum and to the sphenoid, and then get into the cella. Though it is a 3D image and you have the ability to use both the hands, the limitation is the axis. You can only see the straight line, and the most of the times the gland or the tumor that is present beyond the line of your straight axis of the light is missed out, especially extensions into the lateral, posterior, superior sometimes, and anterior. All these extents used to have a lot of difficulty approaching the tumor and removing it through the microscopic surgery. The another challenge was that because of this limitation, quite often, though we believe that we have done the complete removal of the pituitary tumor, post-operative scans do show significant amount of residual tumor. And that is how people started, going back and again operating, and later on some of them submitting them for radiotherapy. And this went on. One thing in my own experience and with the literature and with the other colleagues all over the world, we realized that it's a benign tumor and there's no point in giving radiation, though they respond very well to the radiotherapy. There are innumerable number of important structures starting from the hypothalamus, pituitary stalk, carotid arteries, temporal lobes on either side. And people used to come back after many years with the innumerable number of complications, starting from strokes, developing aneurysms. As such, the incidence of aneurysms are high with the pituitary adenoma. About 4 to 6% of the pituitary adenomas can have an associated aneurysm. That's the reason sometimes, if you're not very careful, you can run into trouble by touching these blebs and causing torrential bleeding into the surgical field. Apart from that, radiation used to cause damage to the pituitary stalk, hypopituitarism, temporal lobe abnormalities, seizures, and memory disturbances, etc. So we realized that it's not worth doing the radiotherapy. So that is why more and more focus was given to try to achieve the maximum amount of reduction of the tumor burden, and total resections, we try to look at that. Now, the other significant problem with the microscopic surgery was that we were unable to see the normal pituitary gland. So its differentiation is so difficult. So over the period of time, and you realize that we have the endoscopes first, of course, they all came into ENT, and then with that, what we are now able to do, use the same technique, and with this, the greatest advantage, you know, that endoscope, though it is 2D image, but you still have a phenomenal amount of panoramic view, and you can see the both sides. The anatomy is so very clear, and not only identification of the midline, which is to be the standard landmark. Often we used to struggle in those days with microscopic surgery, where we used to preserve a part of the vomer so that we don't miss the midline, because that's the crucial point. And otherwise, you can land in serious complications like entering into the cavernous sinus, carotid artery injuries, etc. So now MRI has clearly given a significant contribution, in the sense that preoperatively we are able to see the distance between the two carotids. We can image the carotids and see, you can see the abnormalities of the sphenoid sinus, the septae, so, and the cellular floor, the thickness, pneumatization, and moreover, the important thing is the tumor and its extensions. How much it is extending into. Sometimes tumors can be extended into directly into the sphenoidal area, or it can go into the lateral cavernous sinus and superior, lateral, and posterior extensions, and giant pituitary adenomas and vascular relations can be very clearly identified. So this has given a tremendous amount of confidence, and so that the endoscopy has been extended to the pituitary surgery. Now, still, nevertheless, is not that all the pituitaries are done only nasally endoscopically. Often, if there is a multilobulated giant pituitary adenomas, we do sometimes even transcranial, and at times we can do combined procedures even, where a significant part of the tumor is removed from the transnasal approach, and then whatever is the residual with the lateral extension, which is beyond the neurovascular structures, sometimes will be taken care by a transcranial approach, either simultaneously or at a later date. Now, endoscopic surgery has phenomenal advantages, so not only about the vision, and you are working very closely to the field. And to begin with, we all have started with the single nostril technique. It is a very short series. We realize that there is a limitation of the space, and the movement is very restrictive, and the problems of hemorrhage, and when there is bleeding, is very difficult to manage that with a single nostril thing. We cannot use both the hands, and is a very narrow operative corridor, especially when there is bleeding. Sometimes you need to use both the hands to see the bleeding, at the same time to tackle the bleeding becomes very difficult. Moreover, it's very interesting that if you are not very careful and well versed, you can get into one of those pneumatized areas of the sphenoid sinus, and you will be only going through one half of the sella, though apparently it gives a feeling that you have opened the sella fully. And this all the pitfalls that we have experienced during the single nostril technique. And afterwards we switched over to binostril technique, and most of my cases we have done along with Dr. Prahlad has been very helpful, and it was wonderful working with him, and we learned each other, and we built a series. And not only that, the results have significantly improved after the combined technique, because ENT surgeons are very familiar with the ENT corridor, and there are many variations. Each individual have their own anatomical variations, and you are very well versed with. And though we all think is a technically more or less simple technique, straightforward technique, there are so many subtle minor variations one need to do in order to make tailor-made for that individual person, so that we'll achieve the maximum goal of reduction or tumor removal. So these modifications can be done only when we do jointly with both the ENT as well as the neurosurgeons, and it has worked with me very well. And now that's the trend, and most all over the world, all my colleagues, most of my colleagues, they do a jointly these approaches. Of course, there are few who do individually, and this is the principle of binostril technique, where you can use both nostrils, and you have to have 4 instruments, and 4 hands. That's how it is. You can identify that Prahlad there and next to me there. And this is how we use that. Apart from there is advancement of the instrumentation, the endoscopy and the cameras. We have a phenomenal advantage today of having the navigation, which you can, I think you can't see the marker here. You can see at on the top of the navigation where the MRI image is transported into this computer, and it can exactly tell us where we are during the surgery. The position with instruments, we can identify the position very exactly, so that two great advantages. Whenever there is an anatomical disorientation or a confusion, you will be able to identify the exact location where you are. And whenever you know that there is an important structure, you can verify again, putting a probe there and then looking at the MRI instantly, and it can be related to what structures. The most important thing what we are always worried about is the carotid arteries. But because of this, even though now we have very narrow corridor, the confidence levels, not only with the experience, but with the neuronavigation imaging, has tremendously increased. Earlier, when the carotids are very close, we never used to attempt trans-sphenoidal surgery at all, especially with the microscope. With the endoscope, the confidence levels are so much, unless the carotids are so close, what we call as kissing carotids. Rest of the times, we are able to go ahead and still do a trans-sphenoidal surgery. That's number one. Number two, when the floor of the sella is so thick, sometimes the sphenoid sinus is not pneumatized at all, even then we can identify the landmarks with the help of the navigation, and we're able to drill it confidently. Now, while we do that, when we extend laterally and take off a little more of the bone, we even mobilize the carotid arteries a little more, so that we get the corridor enough to approach the sella and remove. And third thing that has helped during the navigation is the young children. Young children, sometimes we never used to do trans-sphenoidal surgery because of developmental abnormalities, lack of pneumatization, and very, very narrow corridors. Now, with the finer endoscopes which are available today for the pediatric use, and also with the help of the navigation, we are able to go ahead and drill the sphenoid, even if it is not pneumatized, approach the sella very comfortably. So that is how is not only the pituitary surgery, and even for the extended pituitary surgery or extended trans-sphenoidal surgery, what we call, for the supracellular lesions like craniopharyngiomas and some of the meningiomas, arachnoid cysts, etc. The endoscopic route has become as popular than the microscopic surgery today. And the last but not the least advantage is that you are instantly able to see the extent of tumor reduction and removal in the with the help of the navigation. So as you are removing the tumor, you can identify, and when the total removal is achieved, and when the diaphragm is collapsing into the field, and you can check that you have reached the most important completion part of the tumor surgery. Earlier, to achieve the same thing, we used to do many techniques like air insufflation, putting a lumbar drain and injecting air to push the diaphragm down, tumor down into the field. But all these techniques was useful, but never gives a total confidence than you seeing directly and confirming with the navigation that you are able to remove completely. So this is possible today with the combination of both the endoscope, where you are able to see the field completely clearly, and you can identify the cavernous sinus wall, the diaphragm, the lateral recesses on either side, and so that you know very clearly that you removed the tumor completely. Now, you look at this, so one of the videos I will show. This is the Doppler which I am using, so that you can identify and try to go as laterally as possible. Now, whenever we are opening the bone widely, the sphenoid sinus and the floor of the sella, and the carotid is the one which can have abnormal loops sometimes, and they can be very close. So you need to be very sure for two reasons. One, to have maximum possible bone removal so that your hands can move freely. At the same time, you can also get a clear idea how much dura you will be able to open. And you should have a a wider exposure as much as possible you see here, and both superiorly, inferiorly, of course, you will know that up to that clivus, whereas lateral is the one where you need to have maximum amount of bony removal, which will help you in moving the hands very clearly. So, this is the Doppler. We can use that, and if you hear the noise of the carotid, you can pick it up, and then you know that which are the areas you need to avoid, either to punch the bone or to open the dura. Now, in these locations, it's safer actually to drill rather than a punch the bone. Sometimes the dura can be so thin when you're punching, when pulling the bone, it can damage the carotid artery. So if when you are doing a very good diamond drill on the other side, you have a better control of the whole system. Now, after that, what we do is once you open the dura, now general tendency is to use the scoop. So you should never use the scoop. You take a biopsy if you want, and then what you do is try to get a plane, start from the inferior edge of the tumor, and then keep on developing the plane all around. Start with the inferior and then lateral. And when you come to the superior, you need to be very, very careful, because that is the plane where there is a stalk and normal pituitary is there. So when we started achieving a complete radical resections of the tumor, you can see that now. You see that stalk there underneath that. That is the normal, usual position of the stalk. So I can go back here. So you can see that when you remove the tumor, and that's the normal pituitary gland there. And when I push the gland, you can see the stalk there. So that's the beauty of the endoscopy, where you can see that. And when you are doing this maneuver, I mean, unless you are very gentle and experienced, don't try to do that, because when you're doing that, you can disconnect the pituitary gland from the stalk. So now once you start looking at these normal structures, your confidence levels will keep increasing. So you will be able to preserve that, which was never been possible when we're doing the microscopic surgery. When we do a normal pituitary surgery, the first initial goal was to get a complete radical removal of the tumor. So when we started achieving that, and then we started looking at the possibility of looking at the normal gland. So what is the most important leading indication that how to identify the normal pituitary gland is, with an T1 sagittal image of MRI, you will be able to see the stalk very well. And the pituitary stalk you need to identify. That will give an indication that that is the point where there is a pituitary gland could be, because it can be pushed superiorly, it could be pushed anterior or posterior. Majority of the times it is superior and posterior. And the another clue what you get from MRI is the pituitary bright spot. And the pituitary bright spot is supposed to be due to the deposition of the vasopressin levels inside the pituitary gland. And whenever you have the this hormone inside, so that is being a neuropeptide hormone that is brightly seen in MRI, and that gives an indication where the normal pituitary could be. And the third one is the contrast MRI. Sometimes you will be able to see the stalk very well, and we need to know the clear anatomy so that you will be able to identify that. In some difficult cases, we have also tried the MR tractography, a technique which is a little difficult, and if it is very well done, I think you will be able to identify the pituitary stalk. And once you see the stalk, and the lowermost part of the pituitary stalk usually represents the normal pituitary gland, and that is the area you need to be very, very careful. And when you start dissecting the pituitary adenoma, you should go to that place at the end. So now, tumor of the pituitary can be predominantly in the anterior lobe, and quite often they are central, and sometimes it is lateral. Now, there is a situation where there is a small tumor intraglandular. These ones can extend into the stalk, and these are the ones sometimes you need to be very careful. You need to make a very sharp incision there so that you can preserve this and get the tumor off. Now, the technique how we can achieve two important things is, one is maximum or gross total removal of the pituitary adenoma. At the same time, preserve the pituitary gland is by first thing to have maximum dural exposure that is possible. And then you also should have a good dural opening, enough for both the hands to move. And very important thing is before you open the dura, the bone around that has to be drilled so smoothly, nicely, so that there should not be any excursions. And if there is undulations in the bone, when you are moving the hand, it will jump your hand, damaging the gland, stalk, sometimes the disconnecting the pituitary gland. Now, it's always is a must that you must do the bimanual dissection. Always start from the inferior part of the gland, then go to both the lateral sides, and then go to the last superior area. Now, there is always a pseudo capsule between the pituitary adenoma and the normal pituitary gland. Was never been able to possible to identify with the microscope, despite the best magnificence it can provide. With the endoscope, it is possible that we will be able to get this plane. Now, if we can get this plane very clearly, then you need to be in this plane, never use the scoop and be in a hurry to debulk the tumor. And once you start debulking rapidly, then you will miss this pseudo capsule and then you transgress into the pituitary gland. You will lose the plane between the normal gland as well as the tumor, and then it is very difficult. So always when you find this pseudo capsule, you should be very clearly use the sharp dissection, especially at the superior part where it is very close to the pituitary gland. Rest of the areas inferiorly, you can use the blunt dissection. And once you identify the normal gland, you must follow that very, very carefully till the end of the surgery, and you separate that from the adenoma, and then you can get rid of that. So you can see that this is the pituitary tumor, MRI views, sagittals. You can see the pituitary tumor here. This is the coronal view. So, and you can see the stalk and pituitary bright spot on the superior aspect here. And this is the classical exposure. So the midline, we're drilling that, the omer. You can see that here, I'm showing this case specifically because the bone is very thick here. You can see the thickness of the bone. And then still, we were able to manage that with the guidance and having the proper anatomical landmarks. And always keep checking the depth. And once you drill it properly, you will make the bone very thin, and then you can use the dissector and then get the plane. That's the dura there. You can see that. And then you see that that's a diamond drill now, and that's a Doppler, which I am using to see the lateral extents so that I can plan if there is a possibility to remove the bone further, as well as to plan the dural incision. Now, if I clearly hear that kind of a vascular resonance, I try to avoid that area, and generally we give a crucial incision. When you do this lateral incision, you always make sure the blunt end is lateral so that it will not rush by chance. It will get into the cavernous sinus onto the carotid. You can see that I'm turning the knife to see that sharp edge is always towards the midline. So once you do this step, you see that you have created and don't be in a hurry to cut the dura, including into the gland directly. When you do that, this plane between the dura and a beautiful plane between the dura and the adenoma, you will miss. So you need to be very gentle in opening the dura, just enough that the dura is open. And you see that once you separate the dura and the adenoma, you create a plane there between the dura and the adenoma, and you can already see the difference. You see the upper part looks slightly different. This is something which you need to be very careful, and the lower part is very pinkish, and this is how it looks. And the margin will be like, like a map on the world map, very thin line of thing will be there, and that is how the normal gland and the adenoma junction will be. And there is a very thin pseudo capsule which you need to be very careful about, and never use a scoop. And you see that you separate the first inferiorly all the way down up to the floor of the sella, and then I take the biopsy just to debulk the tumor. Meanwhile, we'll get that. Now you see that when you see that the difference between the normal gland and the adenoma. So you always see a fine pseudo capsule there, as well as a very faint color difference. It is slightly pale yellowish is the gland, whereas the pinkish firm is the adenoma. And when you are using the suction, keep the suction more towards the adenoma. And this is the flat dissector, which is very, very useful, especially to maintain the plane between the normal gland and the pituitary adenoma. Now, the tendency is to go forward quickly and cut off, and if you do that, the gland will come out. So where you cut this adenoma completely like this, you will always see this plane of smooth pseudo capsule kind of a thing. You keep on debulking, and at the end, it's better to use the sharp dissection there so that the plane is maintained and you don't transgress from the adenoma into the pituitary gland, and you cut off that, and above that you can see the stalk, and the gland is completely removed here. So once you achieve that, you can clearly visualize and that is the stalk. Above that you can see the complete clear floor, and you can both corners you can visualize the cavernous sinus wall, and gently be very careful and don't try to break that arachnoid when you're trying to look at the stalk or the superior aspect of the normal pituitary gland, so that you can avoid the CSF leak there. So you can see very clearly there's arachnoidal plane there and the normal gland there. So, and this is the floor of the sella, the cavity of the sella, which is completely free. So when you look at the pathology, you can identify the normal gland. Normally, when I'm in doubt, I take a small piece of that and send it to the pathologist along with the regular one. You can clearly see the normal pituitary and versus the pituitary adenoma, where there is a hypercellularity and the pituitary cells which are enlarged. Now, the greatest advantage of preserving the pituitary gland is that these patients, we have followed up 25 of them seriously, and no endocrinal abnormalities were noticed in of them, many of them, and 4 of them have improved tremendously. So replacement was required only in 2, and the another great advantage is that every pituitary surgery in the past used to have a diabetes insipidus, which is often used to be permanent, and today with this technique, I think the diabetes insipidus, the incidence itself has come down significantly post-operatively. Even though it occurs in good majority, it is quite transient and manageable medically, and very rarely becomes permanent that requires long-term replacement. So we have 2 great benefits here. One is the replacement of endocrine abnormalities becomes lesser and less in these patients, and I have withdrawn a corticosteroid replacement after the 3 months after the surgery, wherever I was confident that the normal pituitary is preserved. And the only hormone that cannot be stopped is the replacement of the thyroid, and that need to be done, I think, lifelong. That is the only problem we have noticed, whereas all other hormones do recover with the time, and the first one to recover is the corticosteroid replacement. Now, the second great benefit is the DI. The diabetes insipidus recovers completely. They all require very transiently the nasal vasopressin or desmopressin are injectable for a few days, and they settle down quite often. The closure is a very important thing, where we use 2-3 layers, where we fill the cellular cavity with a little bit of fat to protect the pituitary gland, and then over that, I think we put the fasciolata and the flap, nasal septal flap, which is vascular or pediculated flap often. So, and then we put little glue so that the sella is filled, pituitary gland is supported, and it also helps the so-called prolapse of the optic chiasm, which is a very rare phenomenon, but it can happen in a few individuals where we see sudden deterioration of vision after the surgery. And this is the first layer of fat, and second is the fascia lata. So, and we put fibrin glue over that, and then we put another layer. This is the nasal septum. Now, off late in some of the small pituitary adenomas where they are confined to only sella and not going to the suprasellar level, we stop doing the nasoseptal flaps and just putting a fat and the fascia lata is sufficient. Now, the third layer in normal situations is that is the nasoseptal flap, which Dr. Hlad is very good at, and uh, this is the flap which comes in. The most interesting part is that we will be able to manage this even for a recurrent pituitaries. Now, that's the most important point. Even though there is a pituitary recurrence, in those days earlier, we used to send them back either for radiation or go for a transcranial surgery. Of late, with this experience, we are confident enough to go back again in the same trans-sphenoidal route if required with the navigation assistance. We'll be able to get a good plane. And interestingly, the opposite side nasal septal flap can be used for the closures. And this is how we do that. In conclusion, it is a trans-sphenoidal endoscopic surgery is a very good technique with a lot of advantages than the microscopic surgery. We got a panoramic view of the, and it also facilitates identification of normal gland, and gross total resections have got is possible. And once you remove the tumor completely, and if you're able to see the clear wall of the sella on all around, including the cavernous sinus on either side and the diaphragm, and is no the higher cure rate is assured, and the recurrence rates are very, very less, and you need not submit these patients for radiotherapy. Now, another advantage of the endoscope is the 30-degree, 70-degree. You can look around the complete area and see all areas the tumor has been removed. The most important is the technique. When you use the fine dissectors and the bimanual technique, and if you don't use the curettes, you will be able to have beautiful planes all around, and that is how you will not only ensure that you remove the pituitary gland completely, but also preserve the normal gland after proper identification. And preservation of normal gland has its own attendant benefits, which I have told that. And though it is a learning curve, is not that I started preserving this pituitary gland right from the day one. After nearly 10 years, I've learned this technique of identifying the pituitary, and the confidence levels today is much more than what it was in the past. So it shows there is a clear learning curve, and results will certainly improve with the time, experience, and perseverance. Thank you very much.
Yeah, thank you very much, sir, for that wonderful talk. You can switch on your video, sir. Now, there are a few questions. We'll take a few questions here, sir. Huh? Yeah, okay. So one is first question, Dr. Suman Thapa, I think from Nepal. That is, how do you close the dura layer after endoscopy? Yeah, after surgery.
Yeah, a couple of my colleagues are trying to put direct sutures, particularly in Japan, and that's the only center they try to close, especially so when there is a profuse high pressure CSF leak. Otherwise, you don't need to suture the dura. Other what you need to do is, as I have told you, you have to have 3-layer closure. Put little fat, and then if required, you can put 2 layers. One is an inlay graft. You take a one fascia lata, put it inside, insert into the edges of the dura, and put one on the overlay. That is called inlay graft and an onlay graft, and then you put the nasoseptal flap. That is one way of doing that. Other, whenever we're supporting the pituitary gland with the fat, I put an onlay graft and then the nasoseptal uh, flap. Now, there are people who we simply pack this and then leave the pack for 3 to 5 days, and majority of the times we get away without any CSF leak. Now, if we think intraoperatively there is a significant CSF leak is there, we always put a lumbar drain, which will remain there for about 3 to 5 days post-operatively. What we do, we remove the pack first, make sure there is no leak, and then block the lumbar drain for a day and then take it out. Now, the other techniques people have been using is that putting a Fogarty catheter there with pressure and also the lumbar drain. And I generally don't do that Fogarty catheter balloon technique because it causes a little pressure inside. People feel discomfort, and if the pressures are not properly managed, sometimes there can be necrosis of the tissue around that, causing more problems. So by and large, we should be able to do that. And if you see the, for example, when we are seeing the normal pituitary gland and trying to look at the stalk, which is seen for the demonstrations, I try to avoid most of the times. But while doing that, if there is a breach in the arachnoid and there is a CSF leak, best way is to take a small piece of fat and plug the hole then and there. And once you plug the hole there with a piece of fat, and it remains there. So these are the various techniques. Despite all this, in about 5% to 10% of people, there can be CSF leak, and then sometimes we may have to go in and then redo the situation. Now, the technique is very important. Whenever you put a flap, you have seen that the surface should be absolutely adherent to that, smooth. You make sure that the whatever it is, fascia lata or the nasoseptal flap sits very smoothly over there without any folds. The moment there is fold, what happens? The CSF seeps, collects, and then with each pulsations, it slowly lifts off the flap, and that's what happens. So that's you need to take few more minutes time. Make sure that it is nicely, it's like plastering, what you do at the end for the floor of the house when it is made. You spend enough time to rub it smooth, become smooth. So you create the smooth surface. So that's very important thing. Now the second thing, when you put the nasoseptal flap back, you make sure that the entire flap sits nicely. Yeah. Whatever is redundant is kept lower down. Okay. Yes, so that's very, very important. Otherwise, most of the times you take the flap all the way up to the bone, and then what happens after you pack? What happens? The bone will hold the flap, and it is in the air in between. In between is not in contact with the cellular surface at all. So these are some of the technical faults that will make the CSF or rather facilitate the CSF leak post-operatively. So once you are careful with all this, it will be very good. And if required, sometimes you can even insert this fascia lata all around gently so that it stays in place.
Yes, Dr. P.V.L.N. Murthy, a senior surgeon from Hyderabad, sir, is asking, do you harvest studded flap in all cases, nasoseptal flap in all cases?
As I mentioned that whenever the adenoma is large and I anticipate CSF leak through that, off late, as I told you, if the pituitary tumor is confining to only to the sella and with a little bit of elevation of the diaphragm, I don't do any flap. We manage, and even sometimes we don't even take the fascia lata. We leave it alone. So that itself will take care. Only because we are preserving the pituitary gland, and gland sometimes needs support. So it is necessary that we take a small bit of fat and put it there. And when you put that fat, we also take a small piece of fascia lata, and just to ensure that there is enough support. Yeah. And when you put fascia lata, one great advantage is that if there is a recurrence by chance, it really guides you. When you go back next time, you can always open it like a lid, and you will not be able to reuse it again, but you can open it like a lid and then get into the cella very easily. With the help of navigation, you can identify the landmarks.
Yes, sir. So Dr. Rahim is asking, do you use lumbar drain in all cases? If not, in what circumstances you use it?
Yes. Lumbar drain I use only when there is a profuse CSF leak during the surgery. That is the primary indication. Now, the second indication is that we normally pack the cella, and after day 3 or day 5, remove the pack, and you start seeing CSF leak. And it is very, not very profuse, very tiny leak. You always tide over the crisis by putting the lumbar drain for 3 to 5 days and keep the patient in the bed. And that will settle the leak. And still, if the leak passes, then you need to go in and do the repair of the floor once again.
Yeah, that's right, sir. Sir, Dr. Abhilash Alex from, again, Kerala, is asking any experience with the Duragen.
Yes, Duragen, we have off late, we started using that, particularly for craniopharyngiomas. Craniopharyngiomas, especially the extended trans-sphenoidal surgery, where the bony opening is much more. We go onto the planum anteriorly, sometimes onto the clivus, and these areas, to put the flap back again, as I said, to get that approximation is very, very difficult sometimes. And in these situations, we have been using this Duragen. So far, it's been very helpful. Whenever I put Duragen, along with that, I also use the lumbar drain. So we need to see the long-term results.
Yes, sir. Dr. Dhanya asking how to diagnose diabetes insipidus post-op, and how do you manage the dose of vasopressin?
The dose of vasopressin is always managed with the urine output. So we need to train the our endocrinologists. Sometimes if they are there, is very good. Most of the times, our neurocritical care people, they will be able to manage, including our neurosurgical postgraduates. They are very well trained with this. Now, the diabetes insipidus is that you identify with the whenever the sodium level is going up, serum osmolality is going up, and there is urine output is going excess, and in 24 hours urine you calculate, and then depending on that, the first thing is you replace the fluid, and then desmopressin can be given in divided doses depending upon the requirement. Now, the reason why we give a titrate every day is that suddenly from diabetes insipidus, these people can switch over to syndrome of inappropriate ADH secretion. So that can cause a problem. So what we do is that very strict input-output chart, fluid intake, both oral and intravenous administration. And then what we do, we adjust depending upon the urine output hourly, we adjust the desmopressin dose. Now, suppose next few hours, the urine output is less, then you can withhold or reduce the desmopressin. So that's how you can keep adjusting. And in some situations, in about 5 days, you will know that what is the average level, and then you can put them like insulin, put them on a fixed dose for a while till it settles down. And some of the craniopharyngiomas, because these tumors are attached to the stalk, which probably sometime later we can discuss, the diabetes insipidus can be very troublesome. So there we use many techniques, intravenous desmopressin and nasal spray, fluid replacement, electrolyte monitoring, and sometimes we do use carbamazepine. It helps for a while. And these are the various techniques that we use to control the diabetes insipidus.
So, Dr. Rahim is asking, accidentally found adenomas, pituitary adenomas, an MRI. You've done MRI for some other reason,
Right.
And you find a adenoma. So how do you decide like when to operate, when not to operate, anything else to be done for these patients?
Correct.
Yeah.
These are now known as, some people call them as incidentalomas.
Yeah.
It sounds very fine, incidentally detected adenomas. Anyway, whatever is the terminology,
Yes,
the surgical decision depends on 3 factors.
Yes,
one, if it is the endocrine active tumor.
Yes, sir.
Now, obviously, then you need to deal with it. So you do the endocrine profile, and if particularly either corticosteroid producing tumor or a growth hormone or prolactin tumor, you have to intervene that. If it is a pure prolactin tumor, then you have a medical therapy available. So, and then you can try the medical therapy. If the medical therapy is not successful, then only you can look at the surgery. That's number 1. Number 2, if the other tumors are like growth hormone, some of them do respond to medical therapy, majority are not. Those situations, depending upon the clinical situations, you decide on the surgical therapy. The third single most indication for surgery is the presence of visual compression. If the optic pathway compression is there, I think it's straight away is better to remove that. In our country, I feel one more indication is that if the patient's follow-up is not reliable, and if he's not able to understand how serially we need to follow, do the visual field, hormone test, and follow that. If that is the case, better to operate rather than going waiting and coming back with a loss of vision. If they're asymptomatic and just simply leave them alone. But they all need to be followed up, because if they're non-functional tumors, they need to be followed up at least once in 6 months with an MRI. For the simple reason, if the tumor keeps enlarging, they always come back with either with apoplexy or with a panhypopituitarism. So if there is a definite evidence of the growth, it's worthwhile removing the tumor so that you can avoid these two potential complications.
Yes, sir. A very precise answer, sir. Dr. Mohammed from Iraq is asking, what are the most common post-operative complications you have faced and how you have managed in
yes,
surgery?
I had my share of complications because of the large series. One of the cases Dr. Prahlad would remember that we have almost removed the tumor, and there is a last part, a small bit of the capsule was stuck to the cavernous sinus, which we tried to remove. There was a brisk bleeding, which was stopped at very ease without any difficulty. So we realized that it could be one of those small vessels, and we left it off. And then 6 hours after the surgery, patient had a bleed, and we realized that it was a branch of the carotid artery which has ruptured. So that was one of the major problems we had, and we had to go back with the endovascular support and then deal with that. Now the couple of times, nowadays we were able to go even into the cavernous sinus, and we see the loops of the carotid arteries and the lateral extensions in between the carotid loops. We know how to go. The simplest way is trace the tumor along, and it leads you into those cavernous sinus areas, and you remove that. And when we are trying to remove that, you can get two types of bleeding. One is the cavernous sinus itself, very vascular venous channels, it will bleed, but all that you need to do is just pack that with the gel foam and hold on, it will stop. The only thing, if there is an arterial bleeding, it will be very severe, and you will identify that because of the nature is a torrential bleeding blocking the entire field. That is the time you should be very, very alert. You should have a very good coordination of your colleague as well as the nursing staff, and the anesthetist should be warned immediately, and you should not become panic. All that what you do is put a cotton pack and hold it and suck around, make sure that your entire field is clear. One of the biggest temptation is every few seconds try to see it is still there or not there. You should never do that. Hold the cotton for 20 minutes by clock without any other thought. So if you hold that to that extent patiently, 90% of the times it stops. Afterwards, meanwhile, you can ask your colleague to take a piece of muscle from the thigh and crush the muscle, put it back, and put a little bit of surgical on that, and majority of the times it stops.
It stopped.
Yes. And in case, if you think you are not confident that it has stopped, you can always check with the angiogram post-operatively and make sure that, if required, there is a problem, you can put a bleb. Long ago, I had a problem. Patient had a bleed and went back. Bleeding controlled nicely. Patient got discharged. 3 months later, he had a tremendous amount of epistaxis. Came back. I knew that it has to be something to do with the sentinel carotid artery. We straight away did an angiogram, and the site of injury, he developed an aneurysm. So this is one of the delayed complications. You need to remember that. So then we need to go in and treat the aneurysm, then the bleeding stopped. So this is the another possibility. Now, the other thing that can happen during surgery is that when you're drilling, especially when you use the punch, is very, very dangerous. Use a diamond drill. In spite of that, the edges, when you are at the lateral edges, there are the intercavernous sinuses, both superior, inferior, and sometimes laterally, can be a tremendous problem. All that at that time, what you need to do is carefully inject glue into the sinus itself. take a 2 ml syringe with the glue and very fine needle. Don't take very thick needle so that the needle puncture itself can produce bleeding. You just puncture the sinus gently, one layer, and then inject the glue. It stops. So that's the fastest way to achieve the bleeding from the venous sinuses all around. And of course, post-operatively, bleeding can be due to many reasons. One is the cavernous sinus bleeding. Arterial bleeding, of course, you will always be able to recognize. And many a times there can be rebound bleeding because you use packing, nasal packing. You have a very good field. Post-operatively, they start oozing sometimes. So that you should be very careful. And if it is a very a small amount of bleeding, you can stop that. You can use epsilon aminocapra acid post-operatively. Those people specifically who have a tendency for the bleeding. And if not, you just hold on. And if it is really troublesome and you think that hemoglobin is dropping and the patient is uncomfortable, then only you need to reopen the pack and then go in and see that. And one of the hints, before you reopen the pack, you should always think what could be the possible source. If it is venous or something, you will be able to tackle it very easily. If you think it's arterial, better to do an angiogram and then go in so that you know what you are dealing with.
Yeah, right, sir. Very precise. There's one practical question here. That is, during revision pituitary surgeries, how to differentiate normal pituitary from fat graft which we fill it in order to close it. Yeah.
Right. See, what happens is when there is a recurrence in the pituitary, the fat graft disappears. For the simple reason, you have the normal pituitary like this is always like a dome, and the pituitary recurrence starts underneath that. As it is enlarging, it probably displaces the fat graft and eventually it gets atrophied and disappears. I haven't seen a significant recurrence having the fat graft. Now, when we get into the tumor, the surgical principles will remain the same, except that you need to be very, very careful in dealing with the superior surface of the recurrent tumor, where you can gently identify the same plane, which is often there. And there are some situations where you will always see that normal pituitary confusion versus the recurrent adenoma. That is where you can do a frozen section. If you have the facility, that is a very, very useful process, and you need to wait about 15-20 minutes. They will tell you it's an adenoma, then you need to remove that. At a couple of situations, though I am seeing the normal pituitary gland, is very much adherent to the capsule. So there, I need to take a call. In fact, one case that Prahlad will remember, we need to take a call, having a future recurrence versus preserving the pituitary gland function. So eventually, I trimmed out significant amount of normal pituitary gland because we do not want to have the recurrence. See, for the patient, recurrence is much more painful than you tell them technically that you have preserved the gland and you are off the medicines. They don't mind taking the medicine sometimes, but never like to have one more surgery in the future. So that way, that kind of a call you need to take intraoperatively. It is always between the discussion. So we have to discuss with your own colleague surgeons and then take a call.
This is about post-op. So when do you take a post-op MRI during follow-up of the patients?
Yes, there are two ways of doing that. If you can do a post MRI within 24 hours, that's ideal, where you don't see too much of artifacts. And that I do always whenever there is a possibility of a problem, if I am not sure that I have removed completely, or if there is some bleeding. Okay. Otherwise, I always do this after a month. Okay. So 1 month later is ideal. One of the important things you need to remember is that today's radiologists are still not very clear that pituitary gland can be preserved. That's number one. So quite often they report it as residual tumor. So it creates a lot of confusion. Okay, that I think you need to be very clear before writing your requisition. You say that pituitary gland is preserved. Right? So then they will look at it. So, okay, otherwise that is the one big confusion that happens. Now, the second thing what happens is when you put fat is all right. Sometimes we put muscle. So the muscle can look like exactly like an adenoma. In 1 month scan, especially when you give contrast. So that is another fallacious appearance. You need to be very careful. That enhancement disappears with time. maybe after 3 months or 6 months, you won't see that enhancement.
Yeah.
But within the first month, you need to be careful about this fact. Otherwise,
Yes.
you will always think that the tumor is left back. And before you think or not, it has been told to the patient that tumor is left out. So it is a big challenge to handle.
Yeah. Yeah, that's right, sir. Dr. Mustafa from Basra, Iraq, is asking, what is the smallest or youngest age you have operated a case of pituitary?
Yeah, 6 years child.
Yes,
For the
very much.
yeah,
Yeah, 6 years. That's right. So 6 years, youngest child was.
Whereas the
So during,
craniopharyngioma is, I think we did about 5-year-old.
yeah, craniopharyngioma patient was 5-year-old. I remember that case, sir. Sir, this thing, the dissection around cavernous sinus. Again, you already emphasized that use of Doppler. Again, Dr. Abhilash is asking, do you use the carotid Doppler for dissection around cavernous sinus?
Regularly, I use that.
Yeah.
Not only before opening the dura, and even after opening the dura. And once I mobilize the tumor adenoma, sometimes you will see small bits of tumor around that area. So what I do is, even then I put the Doppler there.
Yes, sir.
And then see before I try to go into that area. So it gives you phenomenal confidence. That is all. It's not that you. That doesn't mean that your technique has to be compromised. You cannot be careless. You have to be as careful as possible. But if you hear the carotid resonance, you will be doubly careful. That's very good.
Yeah. There's another question about post-op. That is immediate post-op. Whether we keep the patient head up or flat.
30 degrees head up is good enough.
Yeah.
So that's all what is required. You don't need to do the too much of head and up. But keeping flat, sometimes we do after the pack removal. If there is a CSF leak, we put them on lumbar drain. We keep them flat for 2 reasons, so that there's no pressure. Second thing is they don't develop the low pressure headache.
Yeah, that's right, sir. Dr. Harindra Narayana, another very avid surgeon who works with neurosurgeons in the trans-sphenoidal pituitary surgery, is asking, do you prefer extracapular dissection in all cases?
I always prefer that.
Yeah.
You always prefer that. In some situations, you may not be able to get that. So then only I have to go intracapsular, incise and do that. Yes. Now, whenever you have to incise the capsule, we should also remember non-pituitary lesions appearing there. You know, some of the tuberculomas where you will never get that plane. So when you don't get the plane, either in a granulomatous pituitary, hypophysitis, tuberculous pituitary adenoma, tuberculosis of the pituitary, you should always keep that in mind because you will never get this kind of a plane there. And the dura is very thick, adherent. And in that situations, I use very sharp dissection, leaving the superior part. That's how it is.
Yes, sir. Dr. Harindra is my senior, sir, from PGI. He is in Mysore. Yeah. Yes. And Dr. Anu.
I think once we spoke to him, yes. Last time, you remember when we.
Yes, sir.
Yes.
Dr. Hanukaran Mahajan from Amritsar is asking, any nasal dowsing indicated, contraindicated post-op?
I mean, some people have been, I was told that there is a lot of crusts that are falling and they use that douching. But I generally don't do anything. In case people complain of any discomfort and a lot of crusts falling, we advise them plain saline nasal drops to continue for at least a couple of weeks. Most of them will settle down. And always when they do forceful douching, a little bit of blood will come and then that will create panic for the patients. It's better to avoid that.
Yeah. So some surgeons are, they prefer T-shaped incision for the dural incision instead of cruciate incision nowadays. Like, any comments on that?
The surgical incision I also keep changing often. In this situation where I think based on the Doppler, I think we felt probably crucial is better. And quite often we do that crucial is better because you get a clear 4 flaps where you can, you can see the superior part where the pituitary gland can be protected. Now, the other ones is the cruciate is much easier. Cruciate incision is easier, provided, in the superior corners is the one where the carotids come very close. So that's something which you need to be very, very careful. Whereas in craniopharyngioma, the incision is always horizontal. I make sure that the pituitary gland is down.
Yes, sir.
And then we go above the pituitary. So there are
Yes.
different incisions which can use. I mean, it's,
Yes.
it's
Yes.
individual choice and comfort. There's nothing like that. One is superior or better.
Yeah.
Sometimes it depends on the case. And sometimes I extend the superior incision, even pituitary adenomas with supradiaphragmatic extension of pituitary glands. We go up, we remove a little more bone above and up. That is one technique I use that. Second thing is I don't open the dura, but I open the bone so that the dura becomes little more movable. So these are the two things we can use always.
Yeah, yeah, right, sir. One more post-op question. Question about post-op care. Like how long patient stays in the hospital after the surgery?
Yeah, 5 days.
Yeah, 5 days. Precisely. Yeah, yeah. 5 days is there. So I think, yeah. Any more questions, friends? It appears those are all the questions, sir. And audience, they're very happy. The sir is, you know, they're a very knowledgeable session. They're very happy about the session, sir.
I was in a dilemma through more videos and more talk. I thought there
no,
are
sir,
different scenarios, but I thought the principles I thought I'll show you.
Yeah.
Sometime we can look at different scenarios, cavernous extensions, etc.
Yes, sir. Thank you very much, sir. Look forward to have more sessions from you, more topics in this topic. These are dedicated audience who are, you know, keenly focused around these topics. Thank you very much, sir, for wonderful session.
Thank you very much.
Yeah, look forward to have you again on this thing, sir.
Sure, anytime.
Yes,
thank
sir.
you.
Thank you.
Thank you, Dr. Prahlad. Thank you very much.
Yes, sir. Yes, sir. Thank you very much, sir.